Our next session is another interesting one, is PSMA Theragnostics, Paradigm Shift in the Management of Prostate Cancer. For this session, may I request our chairpersons, Dr. Mano Shah sir, Dr. Debashish Chaudhary sir, to come over the dais and introduce our speaker.
Good afternoon all. Our next topic is PSMA Theragnostics, a paradigm shift in management of prostatic cancer. Well, this is a very relatively new modality. We have this facility in this part of the country. I would like to welcome Dr. Punit Sharma, the senior consultant at Apollo Multispecialty Hospital. Well, he needs no introduction. He's a very talented young scientist with a huge background of experience and publications and members of many boards. Without wasting time, I would just ask Dr. Sharma to go ahead with his speech.
Thank you, sir. Good afternoon, everyone. What I will try to do in this session is give an overview of what PSMA Theragnostics is, what is the current evidence for it, where it can be used, and what are the future directions, and a brief overview how we do it at Apollo, Kolkata. So coming to Theragnostics, what Theragnostics basically is, it's combination of therapy and diagnostics. So you select a molecular target in a cancer, for example, PSMA for prostate cancer or somatostatin receptor for neuroendocrine tumor. Then you use radio-labeled compound for imaging and therapy of those cancers. If you use an gamma or positron emitting radionuclide, then you do it for imaging, a PET CT or SPECT CT. And when you use an beta or alpha emitting radionuclide tagged compound, use it for therapy. What you can do is, with this method, you can specifically identify patients who will benefit from it with the imaging and then deliver targeted radiotherapy with precision. So that's the basic concepts behind Theragnostics. Coming to PSMA, it's a transmembrane enzyme which is overexpressed in prostate cancer cells. As the cancer becomes more aggressive, for example, with a higher aggregation score, high PSA, or becomes castration resistant, the PSMA expression in these cancer cells increases. It is also expressed in other cells like normal prostate and especially normal tissues such as lacrimal glands or salivary glands, and that can lead to some side effects that I will discuss later. It is also expressed in certain other cancers, for example, SCC, RCC or glioblastoma, but here the expression is not on cancer cells but the neovasculature, hence not that useful for Theragnostics in this subgroup of tumors. So this is an overview of Theragnostics. So you select a target, for example, PSMA for prostate cancer. You select a ligand, then you tagged it either with an gallium or F-15 for imaging, or you with an alpha or beta emitting radionuclide like lutetium-177 or actinium-225 for therapy. Once it binds to the target, it is internalized. If it's a gamma emitting particle, you can use it for imaging like a PSMA PET CT. And if it's an alpha or beta emitting particle, it will cause cell damage and cell death, and you can use it for therapy. This is an just illustrative case, a patient metastatic castration-resistant prostate cancer, post-docetaxel progression. This is the PSMA PET CT extensive metastatic disease with high PSMA expression, as you can see. Patient PSA was around 396. Patient given 1 cycle of lutetium PSMA. This is the post-therapy scan, which shows that there is high concentration of the therapeutic radionuclide. Then after this, the patient received a second cycle. On second cycle post-therapy scan, you see that most of the lesions are not showing uptake. The PSMA has fallen down, and the response assessment PET CT shows that most of the disease is gone. So this is the basic principle for doing a PSMA Theragnostics. Now, coming to evidence, while PSMA Theragnostic was being practiced in Europe and India for almost a decade, in USA, the trials began a bit later because of radiation safety guidelines there. So the trial which brought focus on PSMA Theragnostics was a vision trial which compared PSMA 617 lutetium labeled compared to standard of care. This patient had either one or more metastatic sites with high PSMA expression on PET-CT and had received one or more ARP inhibitors or one or more taxane-based chemotherapy and had adequate functional status. In this group of patients, as you can see, compared to the lutetium PSMA arm versus standard of care, there was significant improvement in progression-free survival with an hazard ratio of 0.4. For overall survival, there was again improvement with a hazard ratio of 0.62, increasing from 11.3 to 15.3 months. Coming to first symptomatic skeletal event, the time duration increased with an HR of 0.5 from 6.8 to around 11.5 months. The PSA response was significantly better with around 46% patient achieving a PSA response of more than 50% and 80%, more than 80% in around third of the patient, that is 33%, versus 7% and 2% in the standard care alone group. Even the patient reported outcomes such as bone pain intensity or a quality of life, these were also significantly better in the PSMA arm. Coming to adverse event, the grade 3 toxicities, the 3 or more toxicities were a bit more on the PSMA arm, mostly related to bone marrow suppression. One of the toxicities which we are much concerned about is xerostomia, because lutetium PSMA or actinium PSMA, they go to normal salivary gland and cause radiation toxicities there. However, severe xerostomia was not seen in any of the patient. Mostly the side effects were related to bone marrow suppression with anemia, leukopenia and thrombocytopenia. Based on this trial, the NCCN finally approved PSMA as a category 1 with a category 1 evidence for patients who have received at least one novel anti-hormone therapy and one line of chemotherapy, usually which is docetaxel. Then there was another trial, the therapy trial. It was a phase 2 where they compared lutetium PSMA versus cabazitaxel in patients who have progressed on docetaxel. However, the selection criteria for the patient was different, and it was based on both PSMA as well as FDG PET-CT. So patient who had a very high PSMA positivity and no FDG positive and PSA negative disease, only those were selected for lutetium PSMA therapy. Even in this trial, there was a better PSMA response rate in PSMA versus therapy versus cabazitaxel arm, better imaging response from 49% to versus 24%. There were less grade 3 and 4 toxicity, which was around 33% for the lutetium arm versus 53% for the cabazitaxel arms. The progression-free survival was improved, and HR was around, hazard ratio was around 0.6. Now, how we do it at Apollo, what we do is we follow the European Association of Nuclear Medicine and the Society of Nuclear Medicine and Molecular Imaging USA guidelines. What are the patients who are appropriate, what is the appropriateness criteria for selecting a patient for PSMA therapy? The most appropriate patients are patients who have received at least one ARP inhibitors and at least one line of chemotherapy and then progressed. Those are the most appropriate patients. However, castration-resistant patient after RP but who are not fit for chemotherapy or do not want chemotherapy, they can also be taken, but the appropriateness reduces. For castration-sensitive prostate cancer, as of now, there is not much evidence to use PSMA therapy. For selecting patient, the EGFR should be at least more than 30 ml per minute. There should be adequate marrow function with hemoglobin more than 8, whole body WBC count more than 2,000 and platelet more than 75,000. And such patients can be taken up. We select our patient just based on PSMA PET-CT. We don't use FDG PET-CT for selection of patients. The PSMA PET-CT can be either gallium labeled or F18 labeled, depending upon the site. Both those are equivalent. And the PSMA scan should be done within 3 months or at last progression. On PSMA PET-CT, majority of the disease should be showing high PSMA expression with no large measurable PSMA negative disease. This, what considered large measurable PSMA negative disease varies. For example, for a solid organ lesion, a lesion more than 1 centimeter, with a bone-associated soft tissue more than 1 centimeter, or a lymph node with short axis diameter more than 2.5 centimeter and not showing PSMA expression is considered as a PSMA negative disease. PSMA can be administered on a daycare basis, but many patients require an one-day admission for insurance purposes. You have to hydrate the patient, pre-medicate, and we administered a standard dose of 200 millicurie of 177 lutetium PSMA 617, taking all the radiation safety precautions. We can give around 4 to 6 cycle at an interval of 6 to 8 weeks. Some authors have given up to 8 cycles as well, but as of now, the guidelines say up to 6 cycles. And the interval and number of cycles can be varied depending upon the response and toxicity. Now, this is what has been approved. Now, what is the future direction for PSMA therapy? How would we sequence it in future? So there are multiple trials going on. One of them, for example, is there in role for PSMA therapy in a new adjuvant setting in patient with high-risk prostate cancer. The results of this luteectomy trial come in. It was a phase 2 trial. They assessed the safety and whether it was giving adequate radiation dose. And after lutetium PSMA therapy, did the surgeon face any difficulties while performing the robotic prostatectomy? And all these counts, it showed good results. The overall survival and PFS data is yet to mature. Then there are trials going on for castration-sensitive prostate cancer, the upfront PSMA trial and PSMA addition trial, where you can add it to either RP or ADT and then assess the response. The results are awaited. For castration-resistant prostate cancer before chemotherapy, the data of this study, PSMA-4, has recently come in, where they compared lutetium PSMA 617 versus a second-line ARP inhibitor, and then showed that the progression-free survival was better in the PSMA arm. However, the overall survival data for this is not available yet and need to mature and will be published maybe soon. Some other trials like SPLASH and ECLIPSE are going on, comparing another PSMA compound, that is PSMA-INT, with a second-line ARP inhibitors. And of course, there are trials going on for combination therapy, such as with immunotherapy, chemotherapy, RP, olaparib, and so on. So we'll see where we go. Before I end, I will just give a brief overview about the targeted alpha therapy. The most important compound in this regard, which has been widely evaluated, is 225 lutetium actinium PSMA. As compared to 177 lutetium, which is an beta emitter, actinium is an alpha emitter. So it has a high linear energy transfer. So it gives more radiation dose. And since it's a larger particle, so the range is short. The range is limited either to the cells or adjacent cells. So the damage to adjacent normal tissue is much less. Multiple studies have shown that it is more efficacious than lutetium 177 PSMA with lesser toxicities. Clinically, it should be more suitable for patients who have diffuse bone disease, the superscan patient who have extensive marrow and bone diseases. In those patients and patients who have progressed on lutetium PSMA, those patients might be suitable for it. However, the cost is quite high and supply of actinium is limited because now the supply is being diverted to Europe and USA. So as the supply and cost improves, maybe we can do much more. Whatever the published literature is there about actinium, it has shown good rates. However, randomized trial data, some are going on, but data is still to be available. To conclude, PSMA Theragnostic is now an important part in the management of metastatic prostate cancer. It can provide a precise, specific, and effective form of treatment in this patient. Currently, it is recommended for metastatic castration-resistant patient after failure with at least one line of chemotherapy. However, as more trial data come in, I hope and I think it should move up the ladder, possibly comparable to chemotherapy and so on. Thank you for attention.
Now I would like the audience, if you have any question. We can take 1 or 2 short questions. Yes, please.
Because there is a GFR less than 30 ml you mentioned as and the second is, in those patients who have GGFR of 50, is actinium any safer compared to lutetium? How are they saying?
So for patient with impaired renal functions, The main toxicity is not the renal toxicity, it is the bone marrow toxicity because it is excreted through the kidney, so it circulates longer. So bone marrow toxicity is much more likely to appear in the patient. And for patient with actinium versus lutetium, although we don't have data, but since they are excreted through the same pathway, we don't expect that there will be much difference, but because of the GFR thing, but actinium in general tend to have a lower toxicity, bone marrow toxicity profile compared to lutetium anyways.
Dr. Punit, thanks for excellent deliberation. Can you tell us what is the follow-up protocol for you?
Okay, sir. So the standardized follow-up protocol for PSMA is you follow up the patient after giving every cycle at 6 weeks, 3 weeks, you assess the hematological and renal function. Then at 6 weeks, you again PSA, hematological and renal function, and if the patient is fit, then you take it for the second cycle. The second cycle can be given at interval of around 6 to 8 weeks. And you give 3 cycles and then you reassess with imaging. Currently, most people do it with the gallium PSMA imaging, but you can do it with the bone scan and CT scan as well. So that's the usual protocol for the patient.
So I have a question, Dr. Punit. Yeah. So basically now, as per the guidelines, we have PSMA after ARPI, then chemotherapy, then PSMA. So as you very well showed the PSMA 4 study, which was just recently. So how comfortable are you? I mean, we are saying here, so now we have docetaxel as a second line. Suppose we are starting ARPI. Now if we can have PSMA in the second line, how comfortable are you in utilizing the PSMA 4 study in your clinical practice?
Frankly, at this point, maybe I won't be that comfortable. So I would maybe prefer to do a second line RPs rather than going for it.
So let me be the devil's advocate again. So you know second line docetaxel is again a very big challenge.
Sure.
Not all patients will be very good. And anyways, ARPIs after ARPIs won't work. So in this setup, I think PSMA 4 study actually gives us an option at least. So
true, maybe a bit more mature data, overall survival data comes in, then maybe we will be able to use it.
thank you.
Any questions? Well, I think that's all. Thank you, Punit. Thank you, Dr. Punit. This last 10 minutes or so was as if we were going through a review article, compiling everything, telling us about what is about PSMA therapy, be it lutetium or actinium. Thank you, Punit, for this nice article.
Thank you. Before we conclude the session, may I request Dr. Manu Shah sir to hand over a memento to Punit as a token of appreciation. Thank you.